Good morning, good afternoon, and good evening. Thank you for joining us. My name is Paige Larkin, and I am the Clinical and Public Health Microbiology Program Officer for the American Society for Microbiology. Welcome to the ASM webinar, Importance of Diagnostic Networks to Ensure Equitable Access to the Clinical Microbiology Services. This is a joint webinar between ASM's Global Public Health Programs and Clinical and Public Health Microbiology. I will be your moderator for today's session. ASM Global Public Health Programs is dedicated to strengthening laboratory capacities in LMICs over the past few years. GPHP has led programs in over 20 countries, addressing over 35 pathogens through nearly 100 trainings for over 400 laboratories. If you want to learn more about the GPHP programs, please visit their website. My colleague will enter in the chat box. ASM Clinical and Public Health Microbiology has also formed a lab equity working group. If you're interested in joining or learning more, please reach out to the email that will be provided in the chat. We will begin the webinar and presentation from our two speakers. After the presentation, I'll present your questions to the presenters as the time allows. We are joined by today's presenters, Dr. Heidi Albert, the Principal Scientist for Access at FIND, based in Cape Town, South Africa, and Dr. Joel Manyahi, a Senior Lecturer in Microbiology and Head of the Microbiology and Immunology Department at Muhimbili University of Health and Allied Sciences. Dr. Heidi Albert has more than 20 years of experience in tuberculosis diagnostics development, implementation, and diagnostic network strengthening in low and middle income countries. She currently serves as the World Health Organization Global TB Program Technical Advisory Group on tuberculosis diagnostics and laboratory strengthening, and has contributed multiple global and national TB diagnostic guidelines and tools. She leads FIND's work on diagnostic network optimization, supporting countries to improve access and efficiency of integrated diagnostic systems. Dr. Joel Manyahi has been involved in research and consulting pertaining to antimicrobial resistance and the diagnosis, control, and prevention of infectious diseases in resource-limited settings for the past 12 years. Working with ASM in Tanzania, he has built the local capacity of the laboratories in the diagnosis of infectious disease, as well as improved surveillance of healthcare-associated infections and antimicrobial resistance. At the national level, he has been provided technical expertise in Tanzanian medicine and medical devices on in vitro diagnostic platforms. Before we begin their presentations, I want to remind everyone of a few housekeeping items. Dr. Heidi Albert and Dr. Joel Manyahi will each give their presentation, after which we'll answer questions from the audience. We've set aside the last 15 to 20 minutes dedicated to questions. This webinar will be recorded and the recording will be posted on the ASM website. The audience has been placed on mute. If you'd like to submit a question to the panelists, please use the Q&A box to ensure your question is seen. I will then share that question at the end. If you have any issues with sound, visual, or other IT issues, please use the chat box and we'll have someone assist you with resolving your issues. We'll begin the presentation with Dr. Manyahi. Dr. Manyahi, the floor is yours.
Thank you. Good evening to colleagues from Africa and Europe, and good morning to colleagues from America. So welcome to our webinar session on importance of diagnostic network to ensure equitable access to clinical microbiology services. I'll be presenting this from Dar es Salaam, Tanzania. So this is our learning objective. First, we explore the diagnostic tools for clinical microbiology limited laboratories in low and middle-income countries, and then examine causes of inadequate access to clinical microbiology laboratory services. And then I will discuss key success factors of clinical microbiology services. As we know, the disease burden, both communicable and non-communicable disease, is high in low and middle-income country than in high-income country, and as well as mortality is high in low middle-income country compared to high-income country. For example, communicable disease account for 21% of deaths in low and middle-income countries compared to 2% of death in high-income countries. And therefore, clinical microbiology laboratories are crucial for diagnosis of infectious disease in this setting. if you look at study performed in high-income country, you find labs perform millions of testing, and even national reference lab in high-income country perform millions of testing. But in resource-limited setting, there are very few microbiology tests which are performed. So access to clinical microbiology service in low and middle income country is severe and inadequate and inequitable, threatening the achievement of universal health coverage. WHO, UNICEF, and the CDC have proposed the integrated tiered laboratory network with focus on test menu for clinical microbiology. If you look in low and middle income country, laboratory service consists of 4 tier. Tier 1, this consists of labs which are at primary care facilities like dispensary and healthcare centers. In this lab, only point of care testing are performed, like rapid HIV testing and MRDT and urinalysis. And also they have equipment, in terms of equipment, they have only simple microscope where they can do direct and gram staining. In terms of human resources, in level 1, they're supposed to have technicians. And also the dispensaries and healthcare, they can sample specimen for referral to high level. And then we have district hospital. In this hospital, we have tier 2 labs. These labs, they're supposed to perform clinical microbiology testing, including culture, identification, speed testing. Also, they are equipped with they are supposed to be equipped with automated and semi-automated microbiological analyzer, like automated blood culture, and they're supposed to perform also eco testing. And then also level 3, these are labs which are located in provisional or regional lab. They're supposed to perform all tests which are done in level 2 and level 1, but also they can perform sophisticated laboratory testing. And for bacteria, they can do minimum inhibitor concentration and minimum bactericidal concentration. Apart from that, they're supposed to perform molecular testing like PCR. Then we have tier 4. Tier 4, these specialized lab which are located in specialized healthcare facilities, and they perform all tests which are performed on all 3 levels, but also they can take the lead of training, also coordinating the activity which are done by lower level facilities. But despite this recommendation by WHO, CDC, and UNICEF, in most resource limited setting, they don't have this capacity. You find a country like Tanzania, only 5 to 10% of labs in level 3 and level 2, they perform basic microbiological testing. So actual microbiological testing are mainly performed in specialized or national facilities. But this level 1, level 2, and the level 3, if you look at this pyramid, this is most patients are seen. For example, in level tier 1, this is where outpatient are seen and where an outbreak could be detected. So what are causes of this inadequate access to clinical microbiological lab service in lower middle income country? First, there's insufficient of human resource and workforce capacity. Then there's inadequate education and training, also inadequate infrastructure, and insufficient quality standard and accreditation. If you look insufficient human resource and workforce, low and middle income countries struggle with the double burden of disease, first bearing the highest burden of infectious disease, but also it has most severe health care workforce shortage. And we know workforce capacity is the single greatest challenge to providing access to clinical microbiology laboratory services as part of universal health coverage. And a country like Tanzania, for example, it has only 23 trained clinical microbiologists, and this saves almost 3 million people per year. And these 23 clinical microbiologists are mainly centered in tertiary facilities or university hospital where they provide training. So you find this leads to inadequate access to clinical microbiological services. But it also there's inadequate education and training. We know competent professionals are key to the delivery of high quality healthcare services. And we know in high income countries have regular standard for medical education, like they have body certification, they have credentialing, and the maintenance of competence and certification. But looking at the low and middle income country, either do not have system in place for workforce, or have inadequate one to assure the quality of education of students or of professional competence for practitioners. But in addition, medical school, they are very little on this resource limited setting. For example, in 2011, there are only 167 medical schools in the 47 countries in sub-Saharan Africa, with only 24 countries having only a single medical school. Some countries like Liberia, Sierra Leone, they do not have university at all. So the other causes of inadequate access to clinical microbiology service is inadequate infrastructures. Most low and middle income countries have inadequate infrastructure to support clinical microbiology services, starting with physical infrastructure of laboratory itself. You find like lab which are Tier 2, they do not have lab facility at all. You know, the lab needs space, they need lighting, they need source of electricity and the plumbing at all. But you find this hospital, they don't have even room for microbiological for the lab. Also, there's inadequate basic equipment. So you find lab at the level of district and region, they don't have auxiliary equipments. So if I give example of Tanzania, for example, there's no district or regional lab which have automated blood culture system. Blood culture system are only found in tertiary or national level facilities. Also, equipment maintenance, they can have equipment, but maintaining of the equipment is also another challenge. Another major challenge is supply chain management. Most have a bit of reagent due to prohibitive cost of reagent is hindering access to clinical microbiological service in this resource limited setting. We depend to get reagent and consumable from outside maybe from Europe or from Asia or from America. And these reagents are quite expensive. So all the logistic chain and shipping, they add up. The cost of buying reagent and consumables becomes very expensive. Also, we don't have laboratory information system. We are based most in social setting that using paper-based information system, which is prone to errors. In developed world, they use lab information management system, which is less prone to errors. Apart from inadequate infrastructure, but also we have most of the social setting have insufficient quality and standard and accreditation of their labs. We know clinical microbiology services are highly technical and therefore require a rigorous program to ensure the accuracy, reliability, and reproducibility of the test result. But access to system for assuring laboratory quality standard and accreditation in low middle income country are inadequate. There's one study which was done in Uganda. They found out of 957, only 5% of the lab met the minimum WHO standard of quality. So this is very worrying. And this, you find the lab in low middle country did not have harmonized the test menu or standardized the operating procedure. So each lab, it has its own standard SOPs. So standardization of the procedure is quite challenging. And few labs participate in external quality assurance schemes. And the very few clinical microbiology laboratory are being accredited. So key success factor which could improve the clinical microbiology service in these countries. So it's been advised tiered and integrated referral network of specimens overseen by national reference lab could improve clinical microbiology service in this country, like using innovation, use of drones to move specimen to and from remote areas. As I mentioned, in different levels, like level 1, level 2, and level 3, they do minimal clinical microbiology testing. So having tiered and integrated referral network of specimen referral could improve laboratory services in low and middle income countries. But and this has been successful for the program like TB and HIV, maybe the nature of disease. And this is a vertical program. I think they have funded by donors. So it's been possible to refer specimen from lower level healthcare facility to high level. Also, advocacy also could increase success to clinical microbiology services. The advocacy role for resource limited setting platform is essential to raise funding and setting the agenda. There have been previous, like Maputo Declaration in 2009 and the Freetown Declaration, which emphasize on a strengthening of laboratory services, especially for HIV and TB. Also, in resource limited countries, they have to invest, provide investment in infrastructure of laboratory. As I mentioned, supply chain management is an issue. You find the country do not have national essential list of diagnostic, so they don't know which reagent and the consumable which are required for microbiological services. For example, recently in Tanzania, we worked with medical store department to ensure in their catalog they include microbiological reagent and consumables, so that we can get this reagent at cheap cost from medical store department. And then if medical store department can do central procurement, they can procure at a cheap price compared to individual lab procuring maybe reagent from Europe or from America. That would be quite expensive, but bulk procurement might lower the costing. Also to have reagent manufactured locally. This was a good example for COVID-19. Senegal was the first country in Africa to manufacture its own COVID-19 testing. And this was quite helpful for testing COVID-19 in Senegal and then supporting other African countries. But also promote general quality management system of laboratory and accreditation. SLIMTA and the SLIMTA revolutionized the laboratory service in low and middle-income countries. For example, before SLIMTA was introduced in 2009, no clinical microbiology, no laboratory was accredited in Africa, apart from South Africa, and Sub-Saharan Africa. But after this innovation by SLIMTA and SLIMTA, by 2017, we have 485 laboratories which have been accredited. But most of these labs are HIV lab which perform HIV testing and TB testing. There are only very few labs which perform the routine clinical microbiology testing which have been accredited, maybe because of the nature of these clinical microbiology labs. So this map shows the sub-Saharan African country which have lab which have been accredited, which has been shown by green color, and you can see the number in each country, the number of lab in each country which have been accredited. For example, Tanzania, where I'm from, 10 labs have been accredited, but these labs are mostly, they do hematology, clinical chemistry, and the HIV and TB. But in microbiology lab per se, they've been, no, apart from HIV and the TB, there's no clinical microbiology lab which has been accredited. So other factors which could have shown success in improving the clinical microbiology service is commitment of funding from donors like Global Fund, World Bank, USD, and Framing Fund. Although this is not sustainable, we've seen much improvement in TB and HIV diagnosis. But recently in Tanzania, the country is participating in the antimicrobial resistance surveillance supported by Framing Fund. As you can see in this figure, there's been exponential increase of number of samples which we've been processing in the labs. These are data from zonal and tertiary health facilities. So Framing Fund supports the surveillance, and you can see in 2021, the number of samples, 2020, there are very few samples, but 2021, the sample exponentially increased, and 2022, you can see both blood and urine, the sample exponentially increased. So though this is not sustainable, but it has increased awareness to the government, even to facilities, even to clinicians. So uptake of microbiology services is now increasing these facilities, but we need to go further to other facilities. But also, we need to strengthen the interface between diagnostics and the clinician. We need to improve uptake and use of laboratory testing. There have been very low uptake of laboratory testing in most resource-limited setting. And you can see the clinician and labs, there's mistrust between the two. So by building the interface between the lab and clinician could improve the uptake, because clinical demand is the one which will drive the microbiological service in this country. Also, integration of point-of-care diagnostics in national laboratory network with focus on connectivity for rapid transmission of test results will frustrate effective uptake of diagnostic program impact. This has been possible for for malaria. There's integration of malaria, MRDT, rapid diagnostic testing, HIV. But for clinical microbiology, we need maybe molecular point of care testing, which could be integrated into our national tiered laboratory network. This will increase connectivity and rapid transmission of test results. So thank you. This is what I have for this late evening from Tanzania. Thank you.
Thank you so much, Dr. Manyahi. We'll turn the floor over to Dr. Albert.
Great, thank you, Paige. And hello, everyone. It's great to be with you today. My presentation is going to follow on from Dr. Joel's and take a bit more of a systems approach, look at the network and how clinical microbiology services are provided and what some of the gaps and challenges might be. So in terms of learning objectives, I'm going to be exploring the system's challenges in implementing clinical microbiology, understand the benefits of looking at an integrated diagnostic system design approach, and then focus a little bit on highlighting the use of diagnostic network mapping and optimization analysis to help us design more patient-centric and also efficient diagnostic systems. So just to kick us off, just to maybe remind ourselves of the sort of scale of the challenge. And in 2019, the data from a landmark study across 204 countries showed us that drug-resistant bacteria caused almost 1.3 million deaths, so more than HIV and malaria. And a further close to 5 million were associated with drug-resistant bacterial infections as well. As Dr. Joel highlighted, the worst effects are seen in low and middle income countries, and the highest rates in particular in sub-Saharan Africa. But we know that there's a similar challenge also in high income countries. And really building stronger laboratory infrastructure for clinical microbiology testing is critical in addressing this challenge. So as mentioned, at the level 2 facility, so the district hospital level lab or equivalent, currently there's a big gap in terms of access to these services. And also the fact that the current testing algorithm is also complex. So just pulling out bloodstream infections as one key example, in 2019, again, the data showed us that close to 1.5 million deaths occurred in that year. And currently the gold standard testing for bloodstream infections would be a blood culture followed by ID and AST, and this can take 7 days or more in these settings. We also know that the available tools are not designed, they're not fit for purpose for the sort of harsh conditions that often occur in these settings, and the cost can also be prohibitive. So just to flag, I think, a topic which could take its own presentation on its own, but as FIND, we are working closely with partners to develop new diagnostics to address these key gaps that we see. So just highlighting a couple of these, one would be enabling increased access to blood culture diagnostics through development of a low-cost blood culture instrument. And a second example would be improving treatment of bloodstream infections through development of a low-cost molecular technology for ID and susceptibility testing. And in both cases, these need to be able to withstand the kind of environmental conditions we see in these settings. So clearly it's important in terms of developing new diagnostics, but what more can we do already with what we already have available? So that's going to be really the focus of the rest of my presentation. And I think this slide is really reiterating some of the key points that Dr. Joel mentioned. So we see currently both limited access to clinical microbiology services, but also very inequitable access. And this is really hindering both individual patient care as well as surveillance efforts in countries. And so what we really need to see is good quality clinical microbiology through a well-functioning laboratory network. And this is, as mentioned, for improving patient management, also providing valuable surveillance data that can be used to inform local antibiotic treatment guidelines and policies, and also supporting containment of AMR and preventing and controlling hospital-acquired infections as well. So there's sort of a two-pronged approach. We need to, first of all, optimize the availability of the tools that we already have, better use of the current technologies, while at the same time planning for future introduction of new tools that we hope will be more fit for purpose. But what we see currently is still siloed systems in terms of diagnostics in LMICs, and much of the investment to date has really been focused on HIV and TB in particular. And then just sort of in general, we know that health systems and diagnostic networks that form part of them are very complex. So even in a given country, we see varying epidemiology, we see variation in geography, and also the health system context. So all these factors are really hindering the availability of quality services. So I'm going to move on and just share a little about diagnostic network optimization, which is one of the approaches that we use to support countries in planning for better access to diagnostic services and more cost-efficient systems and networks. So for those of you who may not be so familiar with the approach, just a bit of an overview. So this is a geospatial analytics approach. It allows us to analyze the current diagnostic network and generate insights around testing demand, capacity, utilization of available capacity, and also cost and accessibility of services. So through this approach, we're able to recommend, analyze what's currently available, and then recommend the optimal type and number and location of different diagnostic services and the associated sample referral network. And this is really aligned with the country's national health goals. We can also use this approach to model introduction of new tools and see where they would fit best within the system. And this does allow us to evaluate trade-offs across different elements. And really its use has been to maximize the impact of investments in system strengthening, so striking a balance between performance and costs. And it's also a really valuable tool that can help facilitate country-led planning and coordination, particularly among different partners and different stakeholders. And its use has been promoted by has been used by quite a number of countries now, and also promoted by some key global stakeholders. So why are we particularly interested in geospatial analytics to help with planning? Well, I think simply put, it really gives us a better understanding, and it helps with making better decisions. Really, it can reveal information that would be really difficult to get just out of looking at data on spreadsheets. We can pick up on patterns, and I'll share more about that, and just be able to model the real world more accurately. So through having these more detailed insights into spatial patterns and trends, it can help us better predict what is happening and what should happen in the future, and just really supports better decision making in country. So this approach can be used and has been used across multiple different diseases. And this is just sharing some examples of the work that we've done at FIND with a number of partners across many countries. And you can see there that there's a range of diseases and testing, everything from TB to Lassa and yellow fever, AMR. So really quite a broad range of different diseases as this approach can help with planning. So the next few slides, I'm going to just share a few examples to give you a taste of the sorts of analysis that can be done. And just to say that there's a number of different tools that are available that can be used for what we refer to as DNO or various forms of geospatial analytics for diagnostic networks. And I'm just going to mention three. And essentially, these different tools have different characteristics, but essentially they differ in terms of the data requirements, the simplicity of the analysis and the need for advanced analytic skills, and also the time and the resources needed to conduct the analysis. So we really tend to recommend a bit of a stepwise approach, or selecting the kind of simplest tools possible based on the data that are available and the particular questions that countries may be looking to answer. So the first tool is looking at population accessibility analysis. And this can really help develop really rapid insights on diagnostic service coverage. The kind of questions that you can answer with this kind of analysis would be, how accessible are the current services to the population? So in terms of travel time, travel distance to the facilities that are providing the different diagnostic services. What does coverage look like? So is coverage equitable across the country? And if not, where are particular gaps and opportunities for improvement? And could coverage be improved with expanding those services, or maybe with the introduction of new diagnostics? And what you can see just on this screenshot, this is from a tool called DXGeoMap that we've developed and we're piloting. And this is just showing that we can look across different regions in the country, and we're able to see what percentage and what population is able to access services within different walking and driving times. So this is really a kind of analysis that requires little data, but can really generate some valuable insights that countries can use for planning. And this is just an example here from Indonesia, where we can see how many people are within a 90-minute drive from particular diagnostic services. So moving on to a second approach, and this is probably maybe quite familiar. This is laboratory or diagnostic capacity mapping, and an example of a tool called DX Explore, but there are many others that can be used to do similar analysis. And this allows us to map and analyze a multi-disease network and identify gaps. So just a few examples here of the kind of dashboards that we would typically see. So the first one is looking at historical testing. So where is testing being done? What are the different device types, and what sort of tests are performed on those different devices? We can see on the top right the testing capacity. So how many tests can be done at a maximum, and to what extent, or where is that being done across the country? So what does the overall capacity look like, in this case by different regions? And then at the bottom, we can see device utilization. So to what extent is the available capacity being utilized? And so this requires also a relatively limited amount of data, a little more than the population accessibility. And we can answer questions like, where are those diagnostic services located? Are they equitably distributed, or are there gaps? To what extent is the capacity currently being utilized? And to what extent could the network support higher testing volumes? So if there are plans to scale up, to what extent can the existing network support more testing? So just a few examples of lab capacity mapping. And the sorts of insights we can see, what is the proportion of different test types? How's that split? What are the different device types that are being used? How does the overall device utilization look? And how do they vary by region? And then finally, this is an example of analysis using an open access tool called OptiDX. And this is really a much more advanced analysis. We can really develop very much tailored optimization scenarios, where we can look at the same time at access, cost, and utilization. But with that in mind, it also requires a lot more data and relatively higher analytic skills to be able to conduct this kind of analysis. But you can see the sort of outputs and the questions are therefore offering much more granular insights. So for example, what is the optimal location of diagnostic capacity to meet the current and future needs? So this kind of analysis can actually recommend the best location, whereas the others you would have to sort of run different scenarios a bit manually to get similar information? How can integration of testing and sample referral work best? What is the optimal mix and placement of different testing devices? And what is the best balance between adding more devices and sample transport? So those are just a few of the insights. So specifically for clinical microbiology, this is related to the WHO strategic and operational framework. And one of the strategic goals is to establish capacity and capabilities to support equitable access to bacteriology and mycology services. And some of the questions that DNO can help address within this strategic goal would be, how can we achieve equitable coverage of testing? How many labs do we need? Where should they be placed? Should we add more labs or equipment, or rather establish sample referral? And can we integrate testing or sample referrals? So I'm going to share a couple of examples just very briefly. The first one is a project supported by the Fleming Fund. And this example comes from Kenya. And the work in this project, the DNO part of the work has quite recently been published, and there on the right-hand side, you can access the link. And essentially what we were looking at with the DNO analysis was how is the diagnostic network for AMR organized at the different levels in the health system? And to what extent could it be improved by leveraging existing sample transport networks available in the country? So I'm just going to briefly show you a few of an example of some of the outputs of the analysis. And here you can see on the left-hand side, we were able to, working very closely with the country stakeholders, to understand the sort of current status of the network, which had been largely established through funding for TB and HIV, and look at different ways of integrating the requirements for AMR testing to see to what extent that could be leveraged and to what extent the cost efficiencies could be gained. And in short, I think hopefully you can see just from a quick look at the results that full integration was the most cost efficient in terms of savings. And then there were a couple of partial integration options which gave sort of intermediate gains, as opposed to no integration, which was the most costly scenario in terms of transport cost. And this was really, as I say, through integrating the different routes, sample referral routes, up to a total of 76% of routes being integrated with scenario 4. So just briefly, both in Kenya, where this example is from, and Nepal, the analysis really created a wealth of insights that the countries were able to use and gain visibility on their network. They used the evidence to establish optimized both sample and isolate referrals. And this also informed development of an operational guide for referrals in Nepal, and also highlighted the potential to leverage those networks for integrated sample referral. And this has been used to guide budgeting and action planning, and also in negotiations with courier services in Kenya. And there'll be implementation of a pilot before a wider scale up. And the second example, I think in the interests of time, I'm going to skip through, but essentially this is showing and the references provided there on the slide, so you can read that if you'd like to learn more. This is an example from Zambia, in which we were able to work with the Ministry of Health and partners to come up with integrated TB and priority HIV testing. And just making the point that in this case, there were benefits that could be accrued to each of the programs. And overall, by looking at integration and optimization of the network, it also resulted in a moderate cost saving as well. So the expected impact of implementing DNO recommendations, the optimized networks are expected to deliver improved access to services, leading to reduced diagnostic delay and hopefully more people being diagnosed and put on treatment in a timely fashion. improve surveillance coverage, leading to better public health decision-making and emergency response, and increase network efficiency, so reduce specimen transport costs, and really allowing then for better prioritization of available resources. And I think last but not least, that the better visualization of the network has really led to strengthened coordination and decision-making across different stakeholders. So key takeaways, firstly, the most feasible and cost-effective way to achieve optimal access to services, in this case, clinical microbiology, typically varies in different settings, even within a country. Visualizing and analyzing the network can really bring a wealth of insights that add value to country decision-making, and incorporating this approach for clinical microbiology can really add value. And the different approaches and tools should really be matched to the country context and priorities. So there's no right tool or right approach, but really matching with the questions that the country has in mind. And finally, just a thank you to our partners and funders who supported this work. And a couple of links here if you would like to access any further information. That's all from me. Thank you. And back to you, Paige.
Thank you so much for your presentation. So we have some great questions in the chat, but first I want to start with a question for you on D&O. So some countries have already done a network optimization analysis for key programs like TB and HIV. Should they be doing a separate one for microbiology?
Yeah, thanks a lot, Paige. Yeah, I think this is a great question that we've been asked a lot, and I think the short answer is no. So I think for a couple of reasons. I think for one, that a lot of the data that would be needed to look at this kind of analysis for clinical microbiology, such as where are the facilities, etc. So a lot of this data would already been collected for these other D&O exercises. So that would be one reason to sort of cut down on effort of collecting the data again. And secondly, I think as shown in that example, we can see that there's, there may not be dedicated funding for clinical microbiology. And even if there is, there's sort of efficiencies to be gained from particularly sample transport, but in future, maybe also integrated testing. So definitely would recommend that countries sort of look at what's been done before and then how they could add on to that for sure.
Thank you. That's a great explanation there. So another question, this one is for Dr. Manyahi. You are thanked for a great presentation, but this participant would like to know, regarding the shortage of facilities and manpowers in the laboratories, what is the role of government or voluntary agencies in assisting these facilities?
Thank you for very good questions. I will discuss specifically for Tanzania. Our government has really tried to improve the manpower in the lab, especially at the level of lab scientists. We have 3 universities which offer degree for bachelor degree in medical laboratory. So, but the challenge has been to absorb this manpower into the system. Employment rate is very low. So despite having a lot of graduates with this biomedical sciences, but they haven't yet been absorbed into the government system. For example, Muhimbili University started to produce graduates from medical laboratory science from 2012 up to now. So scientists, we have scientists, but trained clinical microbiologists, that's been a huge challenge for the country. Right now, we as clinical microbiologists, we've been lobbying the government to ensure that the government supports training. Emphasis has been much training clinicians like surgeons, obstetric gynecologists, pediatrics, but we haven't seen much effort on training the infectious disease specialists and clinical microbiologists. So we are lobbying. We hope this will be successful. But apart from that, international organizations and the voluntary agents have been assisting much on offering on-job training and the offering mentorship program. For example, American Society for Microbiology has been at the forefront in building the capacity of our offering on job training and also mentorship program. This has been very helpful, but I'm not certain about other African setting. But for case of Tanzania, I can say the mentorship program on job training has been quite helpful, especially this offered by development partners.
Thank you. This next question is for Dr. Albert. To what extent is the transfer of technology sustainable after the various projects?
Thank you. Yeah, it's a great question. So what I would say is that with the more advanced analysis, so for example, using the OptiDX tool that I briefly mentioned. So for this tool, we started off by sort of working very closely with the Ministry of Health, but having our team to do the analysis itself. So we co-create and obviously the Ministry of Health are the ones to tell us and work with us to define what are the priorities and what are the scenarios that they would want to consider. But the analysis initially is something that we've done as partners and other partners too. We have been working with quite a number of countries to build capacity for local analysts to do that work. But I think honestly, I would say that it is quite tough, particularly where there's a rapid turnover of staff and people may not be doing this kind of analysis very frequently. And this has really been one of the key drivers for the development of the simpler tools that I mentioned. So the first couple of tools, because these are really things that the countries will be able to take on much more easily themselves. They're much easier to use. I think the concepts are easier and they require less data. So that's really been the big push to those simpler tools, and that's really with a drive so that country capacity can be built much more easily, and then countries will be free to use the tools for whatever questions might come up.
Thank you, Dr. Albert. Another question for Dr. Manyahi. You were asked about, have you thought of or worked on formulating policies in discussion with the government on the necessity to create a friction-free environment for lab products and technologies to move across borders to be able to expand laboratory capacity? Is there any work with the local government?
I didn't get the question. Could you repeat the question?
Yeah, so one of our attendees had asked whether there's a relationship between your organization and working with the local and national government to ensure that there can be movement of products, specimens, et cetera, to help facilitate, national testing. If there's any collaborations with the local national government.
Okay, first I would say, for example, we have an association, association of pathologists in Tanzania. This has been working very closely with the government. So our role has been lobbying in the government, ensure that lab medicine features in the government priority. Although our session is still at nascent stage, but we hope we're going to be successful in building networking, also lobbying the government. So National Laboratory Network, so far, it does exist. We have different systems in the country. We have government-based facilities and the face-based. So we don't have national laboratory networking. That's why even integrated tiered laboratory specimen referral system is not difficult to implement. But also you're asking about creating free environment for laboratory product and technology to meet the needs. In Tanzania, we implement public-private partnership. And we are not only depending on the central procurement. Right now, there are local vendors who do procurement of any product you want from any country in the world. I think this has been possible to address and supply chain management in the country?
Thank you for that. That's a really complicated question to ask, so I appreciate you taking the time to elaborate. We have a question, I think this is for both of you, but given the shortage of clinical microbiology resources and the manual nature of clinical microbiology practice, how can digital pathology be used to potentially expand clinical microbiology and utilize these emerging technologies?
Dr. Joel, please go ahead. I think you'll have more insights on that question than me.
So basically being able to remotely utilize these resources such as digital pathology to help expand access, which is a common question we're getting in the United States as well. So it was interesting to see that question being asked.
Yeah, so it's been difficult to integrate clinical microbiology into the digital platform. It's been easy for radiology, for pathology. I mean, someone could be far away from one center, and using digital platform could be able to like read a slide or read an X-ray and share the results. But for clinical microbiology, it's been quite challenging. Maybe the nature of testing which you perform in clinical microbiology. So maybe we need to think how we could integrate clinical microbiology into digital platform.
Thank you. And we have 2 minutes left, less than 2 minutes left. Dr. Albert, anything you want to add to that? And if not, we can close.
Thank you. Yeah, I think just briefly to say that I think the overall, the sort of digitizing of the health system, particularly when we want to be able to access patient data across the different levels of the health system, both for patient care, but also for surveillance. I think having, definitely sort of digital health solutions is an important part of that. I think this was a very specific question on one aspect of that, but absolutely one of the key areas that we're working at FIND, both in clinical microbiology and more generally, is really that digital health aspect. So I think, yeah, definitely that's going to be very important.
Thank you so much. So this concludes today's programs. The recording of today's events will be available shortly online. We'll also send out a short survey asking participants to provide feedback on today's webinar. If everyone could take a few minutes to complete the survey, we'd greatly appreciate this. Thank you, and especially thank you to our speakers. Wonderful discussion, and have a great day, everyone. Thank you.